Now coming to neuroendocrine neoplasm, these are basically common in the small intestine in case of GIT. Now, gastric neuroendocrine neoplasms may be associated with endocrine cell hyperplasia, autoimmune chronic atrophic gastritis, MEN1, and Zollinger-Ellison syndrome. Now, what is basically the cells like? They have well differentiated neuroendocrine tumors composed of islands or trabeculae, and you know that they have a pink granular cytoplasm with an oval nucleus with a salt paper chromatin pattern. A very important MCQ point. What are the IHC stains? Synaptophysin and chromogranin A. Now, the poorly differentiated neoplasms, they will have a high mitotic rate and Ki67 proliferative indices, and these are basically known as the neuroendocrine carcinoma. They are specifically called as neuroendocrine carcinoma. Similar to neuroendocrine carcinoma at extraintestinal sites, mutation of TP53 and RB is common. So I'll just take you to the basic classification. If we talk about the neuroendocrine neoplasms, these are basically of two types. They are called as a neuroendocrine tumor or neuroendocrine carcinoma. If it is a carcinoma, it is basically having a high mitotic rate and Ki67. So neuroendocrine carcinoma is always poorly differentiated, and they are basically of two types, small cell and large cell. They are always of high grade, and you can see that the mitotic count and the Ki67 has more than 20% of the value. So which means this is so very aggressive. And if you talk about the neuroendocrine tumor, they can be of G1 low grade, G2 intermediate grade, or G3 high grade, and these are basically well differentiated. And based on the mitotic count and the Ki67, you can kind of differentiate between them, but they are basically well differentiated. Here you can see how this salt paper pattern looks like, and this is the image of electron microscopy. You can see these dense neurosecretory granules. Now please pay attention to this electron microscopy findings also, because sometimes these images can be asked in the exam. Now basically they have symptoms based on what kind of substances they produce. The one which produces gastrin will cause Zollinger-Ellison syndrome, and the one which produces vasoactive substances, they will cause cutaneous flushing, sweating, bronchospasm, colic abdominal pain, diarrhea, and valvular fibrosis. The most important prognostic factors are the differentiation, mitotic rate, and the Ki67. I've already mentioned this point before. Now coming to foregut neuroendocrine tumors within the stomach and duodenum, they rarely metastasize and are generally cured by resection. This is particularly true for atrophic gastritis. So foregut में these two words are again interconnected. Midgut neuroendocrine tumors in the jejunum and ileum, they are multiple and they are aggressive. Important point. Hindgut will appear in the appendix and the colorectum, and they can appear at any age. So this completes this small topic. And now coming to this next topic, which is the GIST or gastrointestinal stromal tumor. Now what is this? It's basically a mesenchymal tumor which arises from the interstitial cells of Kajal or the pacemaker cells. Okay. Now what happens over here is that if you talk about the Carney triad, that is having combination of GIST, paraganglioma, and pulmonary chondroma, and it is very important. And in the NF1 also, these patients may also have a risk of increased incidence of GIST. Now what basically happens is that they have mutation in the KIT or the receptor tyrosine kinase, the KIT mutations, and you also have mutations in the PDGFRA or platelet derived growth factor receptor alpha. So in these two genes you do have mutation. Now there's a third type of GIST which is called as the SDH deficient GIST. What happens here is that there is loss of succinate dehydrogenase function, and this causes an increased risk for GIST and paraganglioma, which is known as the Carney-Stratakis syndrome. There are two basic kinds of GIST. Number one is the spindle cell type, and number two is the epithelioid type. If I can just show you this image, you can just say by looking at this that this is basically a spindle cell type of GIST, because it's composed of bundles and fascicles of spindle shaped tumor cells. And if you look at this particular image, this is the epithelioid type, because these cells are plump epithelial appearing cells, as you can see here, without fascicles. Now which are the IHC markers, diagnostic markers? Number one, c-KIT or CD117, and number two, DOG1 or NO1. So these are very important MCQ points, you should remember them. Tumors with mutation in the KIT or a PDGFRA, they basically respond to receptor tyrosine kinase inhibitor. Now let's come to this very important topic, which is the autoimmune atrophic gastritis. You must remember that There is a very important chart which differentiates the H. pylori associated gastritis with the autoimmune gastritis, and I cannot stress any more on the importance of this difference, because you need to know the pathogenesis of autoimmune gastritis and how does it differ from H. pylori associated gastritis. So I'll just first take you through these points that autoimmune atrophic gastritis typically spares the antrum, and it is often associated with marked hypergastrinemia. Okay, so before coming to this, I will just take you through one important understanding that what is the pathogenesis. Once you know this pathogenesis, the remaining points will be easy for you to understand. So what happens in case of here is that there is antibodies to the parietal cells, which is the hydrogen potassium ATPase and the intrinsic factor. So parietal cells के against में antibodies है, and what are the components against which there is antibodies? It is the hydrogen potassium ATPase or the intrinsic factor. Now because of these antibodies, these are basically the CD4 plus T cells which are directed against these parietal cells. So this has an important role, this is an important MCQ point. And now once there is antibodies, that will cause loss of the parietal cells. So now this parietal cells will be destroyed and this will have a loss of function. So because of this loss of function, now there would be consequences. So first we should know what is the normal functioning of parietal cells. Parietal cells के दो normal functions है. Parietal cells causes secretion of the gastric acid, and number two, secretion of the intrinsic factor. Now, because there is a loss of parietal cells, this will lead to absence of gastric acid production, because it is no more being able to secrete the gastric acid. So now because of this absence of gastric acid production, this will further stimulate the gastrin release. So kind of a regulatory mechanism where because of the absence of acid, it will stimulate the gastrin release, which will cause hypergastrinemia and hyperplasia of the antral gastrin producing G cells. This is a very important finding in case of autoimmune gastritis, that because of this hypergastrinemia, there is hyperplasia of the antral gastrin producing G cells, because now the gastrin production has to be increased in response to the decrease in the acid production. So this happens because of the defect in this particular function. Now what about the other factor? Intrinsic factor is also not produced here because the parietal cells are lost. So because of this intrinsic factor loss that's happening, there is a defective ileal vitamin B12 absorption, and because of this defect in the vitamin B12 absorption, there's going to be pernicious anemia. So this is basically the understanding in the pathogenesis. Another important point is that there can be some associated intestinal metaplasia, because of which this can also be named as autoimmune metaplastic atrophic gastritis. तो इतना बड़ा एक नाम है इस चीज का, ठीक है. तो now if I just come back to this, so this entity typically spares the antrum. Very important point, they do not involve the antrum, and it's often associated with marked hypergastrinemia. There's an increase in the gastrin. I've just explained the pathogenesis. Now why does it happen? It is characterized by these important points. Just let's go through these points one by one. So antibodies to parietal cells and intrinsic factor that can be detected in the serum and gastric secretions. Reduced serum pepsinogen 1 concentration, important point. Endocrine cell hyperplasia, important point. Vitamin B12 deficiency, important. And defective gastric acid secretion or achlorhydria. So all these points are important MCQ points. So now if I come back to this chart, let's talk about the differences. As I mentioned that autoimmune one will spare the antrum. This mainly happens in the body. But the H. pylori associated gastritis is predominant in the antrum. One important difference. Next difference is that in the autoimmune, it was the CD4 plus T cells which was the main culprit, and that is why the inflammatory infiltrate here is the lymphocytes and the macrophages. On the other hand, here it is the neutrophils and the plasma cells. Yes, acid production is decreased here, as I mentioned, because the parietal cells are destroyed. There is antibody to the parietal cells, but here this acid production is increased. Gastrin secretion is increased. It is markedly increased over here because of this compensatory mechanism. Okay, along with that, there is also some kind of neuroendocrine hyperplasia over there, right? So this is basically the important differences that I have highlighted over here, and I've already explained you this pathway. So now if I just take you through this image, this is basically the autoimmune gastritis. You can see this inflammatory infiltrates primarily composed of lymphocytes, and you can see this glandular atrophy, and this is the intestinal metaplasia that also happens sometimes, as I mentioned earlier, which you can understand by this presence of this goblet cells, right? Autoimmune atrophic gastritis is characterized by diffuse damage to the oxalic acid producing mucosa within the body and the fundus. The antrum and the cardia are typically spared, the body is involved. With diffuse atrophy, oxalic mucosa of the body and the fundus appear markedly thin and rugal folds are lost. If vitamin B12 deficiency is severe, nuclear enlargement or megaloblastic change can happen. The inflammatory infiltrate is basically the lymphocyte. In contrast to this superficial lamina propria inflammation that is typical of H. pylori gastritis, inflammation in the autoimmune atrophic gastritis is deeper and centered on the gastric glands. So the H. pylori gastritis was much superficial, but this autoimmune atrophic gastritis affects mainly the deeper layers and it is centered on the gastric glands. So if you talk about the clinical features, there can be pernicious anemia associated with this. The other associations can be Hashimoto thyroiditis, type 1 diabetes mellitus, Addison disease, etc. Because of vitamin B12 deficiency, you can have all the other features of megaloblastic anemia. Starting with the peptic ulcer disease, this refers to chronic mucosal ulceration affecting the duodenum or stomach and is almost always affected with H. pylori infection. Now, basically, we have some defense mechanisms, and when there is some imbalances between the defense mechanism and the damaging factors, then we have this chronic gastritis from which this peptic ulcer develops. These are the risk factors: Helicobacter pylori infection, cigarette use, COPD, NSAIDs, alcohol cirrhosis, psychological stress, endocrine cell hyperplasia, Zollinger-Ellison syndrome, and viral infection. Now, gastric peptic ulcers are predominantly located in the lesser curvature near the interface of body and antrum. Now, you know that there are two kinds of peptic ulcers. Number one is the gastric and number two is the duodenal ulcers, right? So, let's talk about the differences between them. So, gastric ulcer में क्या होता है कि lesser curvature में होता है and duodenal one happens in the first part of duodenum. So, basically the association with H. pylori infection is more strong in case of duodenal ulcer. Acid level is also high. Now these two are the important points to diagnose, basically one of them. So if you talk about relationship of pain to antacids, then if you take antacids, then there is prompt relief of pain in the duodenal ulcer, but in gastric ulcer the relief of pain is not consistent. This is number one point of difference. Number two is when you take food, it will relieve the pain in duodenal ulcer, but it will aggravate the pain in case of gastric ulcer. Night pain and heartburn is common in duodenal ulcer. Melena is common in duodenum because it is towards the lower part of the GIT compared to the stomach where hematemesis is more common. Vomiting is more common in gastric ulcer and weight loss is more common in gastric ulcer. Now, very important point that both of them, they do not kind of undergo malignant change, and duodenal ulcer never undergoes malignant change, but gastric cancer can rarely undergo malignant change. So let's talk about these differences between the benign and the malignant ulcer. Very importantly, the location, benign ulcer will happen in lesser curvature and malignant one in the greater curvature. Size is large in case of malignant and irregular. Now this is basically the point of difference between both of these. Talking about the mucosal rugae, if when they stop far away from the ulcer, means if this is the ulcer, then the rugal folds will stop away from the ulcer. This is basically the malignant ulcer. And when they are projecting just outside from this lumen, that is when it is a benign ulcer. So mucosal rugae will project outwards from the margins of the ulcer. So basically the mucosal rugae will stop far away from the ulcer. So if this is the ulcer, then the rugae will stop away from the ulcer. This is the malignant ulcer. And if you talk about the benign, then this mucosal rugae will just start, they will just project outwards from this ulcer. Okay, the floor of the ulcer is necrotic in malignant and clean in benign, and overhanging margins are seen in benign, and hipped up margins and everted margins are seen in malignant. So this is the basic points of difference. Some important points here, that gastric carcinoma is associated with blood group A, and peptic ulcer disease, which we are talking about, is associated with blood group O. Now in gastric carcinoma, alcohol is not a risk factor. Okay, important point to note for MCQs. Now the antrum is the most common site of gastric carcinoma and gastric lymphoma. Now the bleeding that happens in gastric ulcer is because of gastroduodenal artery. In case of duodenal ulcer, is because of left gastric artery. Duodenal ulcer happens in the first part of duodenum. Gastric ulcer happens in the lesser curvature of the incisional angularis. For gastric adenocarcinoma, the gastric antrum is more common. The lesser curvature is more common. Now, if we talk about the fundus, it is the most common site for gastric carcinoma in pernicious anemia and in diffuse type of gastric cancer. Ulcerated lesion on greater curvature is more likely to be malignant. So these are some of the important MCQ points which I have mentioned over here. Now, why does this peptic ulcer happens? Because there are some protective mechanisms. There's some normal protective factors like the surface mucus secretion, bicarbonate secretion, mucosal blood flow, epithelial barrier. All these things are actually protective, but these will be getting damaged, and this balance between the protective and the damaging factors will become imbalanced, and that will give rise to peptic ulcer. So basically, you can see this is the image showing the necrotic debris, and later on, you're also going to find a fibrotic scar having. So you can see here that the peptic ulcers are basically having punched out defect, and the heaped up margins are more characteristic of cancer. So let's talk about this important point, that which are the complications. So you must be knowing that the bleeding is the most common complication of duodenal ulcer, and perforation is the most common complication of the gastric ulcer. Okay, so I hope you enjoyed watching this video and you learned something from me. I would really appreciate your feedback. So I'll meet you very soon in my next episode. And if you like my content, then please consider subscribing. Take care and thank you for watching.